Good morning, everyone. Good morning. Good morning, everyone. I am Councilwoman Felicia Porter, representing the 10th District and Chairperson of the Public Health and Environment Committee. As a reminder, please turn off your cell phones. Joining us today, we have excused absences from Councilwoman Ramos and Councilman Mark Parker, and we also have Councilman Ryan Dorsey in the chamber. Thank you, Ryan. And several representatives. We have Isaiah Martin from the mayor's office, and I believe we have representatives from the council president's office, and the committee staff person is Marguerite Kern. So the committee is reconvening a hearing for understanding psychiatric rehabilitation programs in Baltimore City. And for reference and for context, this is an opportunity for us to examine the accessibility, the effectiveness, the regulatory oversight of PRP services, ensuring that they align with community needs, best practices in mental health and behavioral health care. And today's discussion will focus on improving coordination, accountability, and equitable service delivery. So I'm super grateful that we had this opportunity to reconvene this particular hearing. We've had some great movement at the state level with regards to COMAR 1063, which is, I believe it's really an opportunity for us to engage community, make sure our local behavioral health authorities have a lot more say and opportunity for community input. And so I'm going to turn it over to Adrian from BHSB to provide us with a overview and an update on COMAR 1063 revision. So Adrian, I'll turn it over to you.
Thank you. And then I'll just wait for the PowerPoint. But thank you again for inviting BHSB to give an update on this work. And I also want to thank you, Councilwoman Porter, for your support of us and all the work we've been doing together to make changes to COMAR and address just overall provider quality. So as this is pulling up, I will give just a brief overview of BHSB and who we are. For those who don't know us, we are a nonprofit organization and serve as the city's local behavioral health authority. So what that means is in that role as the local behavioral health authority is we are responsible for working in partnership with the State Department of Health to oversee mental health and substance use services within the public behavioral health system. That includes PRPs and a range of other mental health and substance use programs within the system of care.
I am so sorry,
Yeah,
Adrian.
no worries.
I'm so sorry. 1 second.
Yep.
We're going to take a slight recess. If someone can from Charm TV or the council president's office come to the chamber real quick, that would be great. Thank you so much. We'll be in recess for about 5 minutes. All right. Thank you so much, everyone, for your patience. We'll now turn it back over to Adrian to go through our presentation. Thank you.
Sounds good, thank you. There we go, all right, oops. So I think that this is where I left off, just giving an overview of who we are, but just for some state system context. So we, as I mentioned, are the local behavioral health authority for Baltimore City. We do our work in partnership with the Maryland Department of Health. We are their local arm in overseeing the public behavioral health system. We oversee a range of services within Baltimore City. PRPs are one of them. Amongst a range of other types of programs like crisis services, for example, and substance use treatment clinics. Our core functions are advocacy and planning, managing public funds. We administer around $64 million in funds for services that aren't reimbursable through the public behavioral health system, and also work locally with many system partners, many city agencies included, to make sure that people have access to the system of care. So I was asked today to give an update on the COMAR 1063 regulations. For some brief context, COMAR 1063 are the state level regulations that oversee and govern the public behavioral health system. They are regulations that outline our role as the local behavioral health authority, but they also outline broadly some expectations for all the different types of programs within the public behavioral health system. There are also rules related to licensing for providers within the public behavioral health system, and then just generally overall expectations for provider accountability. It is not advancing now. There we go. The Maryland Department of Health has been going through a revision process of COMAR for almost about 2 years now. They started it several years ago, or 2 years ago, with the intent of working on COMAR to improve provider accountability and quality. I just want to emphasize there are many ways to address provider accountability and quality. COMAR revisions is one tool that we have at the state level and locally to lean on. It is not the only tool. We can go into various other ways to do that later, but I just wanted to emphasize that at the onset, that this is one tool to address quality and accountability. But as I said, they've been looking at COMAR as one of the ways to improve that for the past couple of years. What you see on the screen is the proposed structure of the new draft of COMAR 1063 regulations. There are various chapters. This is how the state is proposing to organize things, starting with the top with some kind of general requirements and general chapters relating to reporting, and licensing, and then later chapters going into specific program types. And that's where PRPs would fall in, is in some of those later chapters. Just for an overview of the timeline, as I said, they've been looking at this for almost 2 years. In summer of 2024, the department released for unofficial comment their draft. They got a lot of feedback from stakeholders at that point, incorporated some of that feedback, but then almost about a year later, they released the official draft of COMAR regulations in the Maryland Register, which is the process that, as you know, all regulations need to go through. They need to be published officially in the Register for public comment before they can become in effect. The department got a lot of comments when they did release them for official release, over hundreds, which is a little unusual. That got the General Assembly's attention. They asked the department to delay adoption of the regulations to allow time to go through all of the stakeholder input. In August, Maryland rescinded those draft regulations and committed to looking through stakeholder feedback and then going through a process to have more of a dialogue about the regulations. And they started that process in January of 2026. They had a convening with many stakeholders at MDH where they went through some of their proposed changes based upon the feedback that they got after the official release. And they are continuing those conversations. The next meeting is still TBD. It's to be convened in February of 2026. BHSB was at the table we've been at the table for this. We were at the table in the January meeting along with Councilwoman Porter, and we'll continue to be there. But I do want to report that there has been some progress for addressing some of our feedback related to the role and authority of local behavioral health authorities. As we've talked about before with this committee, BHSB has been advocating that our role and responsibilities be outlined further in COMAR to help address confusion at the provider level about who and when they should be coming to local behavioral health authorities versus the State Department of Health. But also to give us some more authority around when and how we can work with providers on accountability and quality. Obviously with parameters around that authority, right? We recognize still that we are an arm of the State Department of Health and still need to continue with a strong partnership in any of our work around provider quality and accountability there. But we do believe that LBHAs can, if given some more authority, could really work to drive quality at a system level. So our comments have been focused on ways to improve COMAR to give us that authority. I am happy to say that the department has accepted some of our comments, and one of them being around the licensure process. Again, as we've talked about with this committee in the past, BHSB is not responsible for licensing. That happens at the state level with MDH, but providers are required to come to us to get an agreement to cooperate before they can apply for their licensure. We are not allowed to withhold that agreement, but it is something that we thought that there could be strengthened language around, in particular around allowing us to do pre-site visits before we issue agreements. So that language has been accepted. It is in the most recent draft. We're happy about that. We've actually already even started doing that at the local level with new providers, but it is helpful to have it in regulation, right? It gives us black and white. It's very helpful to have it there. So we're pleased that that has been there. As it relates to the rest of our comments and expanding our authority, we have been told by the department that COMAR 1021 is where they envision that work fitting. So there is no timeline for when the department is going to go after 1021. We've been told it's after they get through the 1023. So who knows when that could be, but it is on their radar. So we will continue to follow up with them on that and make sure that, you know, we continue our advocacy around expanded role and authority. So I know that this committee has been particularly interested in PRPs, so I did want to just highlight what is in the COMAR draft as it relates to PRPs. So as I mentioned earlier, the later chapters in the draft of COMAR, there are chapters for all different program types within the public behavioral health system, so PRPs for adults and PRPs for youth. At a high level, the draft regulations are doing more to define the PRP programs and the types of services that are to be offered. It further defines staff expectations and responsibilities. So defining what type of licensure and experience a staff person working at a PRP is supposed to have. It also outlines the referral process and where referrals can come from, and program eligibility. And then finally, there's service delivery requirements. And I just wanted to highlight the telehealth ones because these are ones that BHSB thinks are good ones. It does require that the PRPs offering group services may not offer group services using telehealth. So that means they must be in person. We think that's good because part of what PRP is to do is to work with people with severe mental illness and foster connection and basic life living skills. So group sessions in person can help foster that, and that no more than 50% of services for individual services can be provided via telehealth. So those are two new provisions we thought were good. Again, I just want to highlight, again, these are still in draft form, they're not in final. So I know there are future meetings the department is looking to convene. These could change and there could be provider groups that disagree with BHSB's position. So just wanted to highlight again, these may not, what I'm reporting today may not be like what's in final form. Related to COMAR 1063 is the pause on provider enrollment. So we have also reported on this to the committee in the past. Also, almost 2 years ago, the department put a pause on certain provider types that can enroll within the Medicaid program. That pause has been extended again another 6 months through June 30th of 2026 for Baltimore City. And the provider types that has a pause on is PRPs, but also IOPs and partial hospitalization programs. There are 9 jurisdictions where that pause has been lifted. Baltimore City is not one of them. So finally, just wanted to highlight a few things that are happening in the legislative session that may be of interest to this committee because they are related to accountability and quality. So as you know, we are in the midst of the Maryland legislative session. There are 3 things that BHSB is really focused on to advance accountability and quality. First is around the budget. We think BHA needs to be adequately resourced so that they can do their job of ensuring provider compliance along with LBHAs. So we are closely looking at the budget and what's been allocated for the department there to ensure that they have the resources to ensure compliance. Again, that is one of the ways that we can be improving provider quality and accountability is using the tools we already have, but we can't have more inspections, right, or more monitoring if we don't have the people to do it. So making sure that BHA is adequately resourced to do that is one of the things that we're focused on. The other thing is increasing reimbursement rates for providers. We know so for the past 2 years, providers have not received an increase in reimbursement rates. That also affects quality. It affects their ability to hire quality staff. It affects their, with inflation, it affects their ability to just meet day-to-day bills. So focusing on an increase in reimbursement rates is something we're also working on with a broader coalition of behavioral health advocates as well. The second thing that we're focused on is certified behavioral health community clinics, which I think we've also talked about briefly with this committee in the past, or CCBHCs. This is a type of model that we have three clinics in Baltimore City, and we think they're really good clinics. They do offer integrated level or integrated type of care that's what we think is a higher quality. They're held to higher quality standards than different types of programs within the public behavioral health system. The payment model is also different, which we think also helps to advance quality. But one of the things that's particularly unique about certified community behavioral health clinics is that they are required to do care coordination, and then they're paid for it, right? Care coordination is working different teams that are working with a particular patient come together and they coordinate that person's care. That leads to better outcomes, and those outcomes are what CCBHCs are held to get paid, basically. So we think this is a really good model to advance quality. We want to see the state continue to advance this type of program across the system and across the state. So we are also advocating that these types of clinics be maintained in the state budget. And then finally is a House bill related to certified recovery homes and unannounced inspections. So this is a bill that was introduced by a Baltimore City delegate, Sandy Rosenberg, who is requiring that what the bill does is that requires certified recovery homes have 2, I believe, unannounced visits in the course of a year. We think that unannounced visits are a good way to assess quality and ensure accountability. I will say we are still looking at the detail on this bill, but BHSB does think this is a good idea and wanted to highlight this for the committee as well. And then the last thing I'll say is always send us complaints. That is another way to improve quality. We've done this before, but this is how you get complaints to us. And I think that's all I have. Happy to take any questions.
Thank you so much, Adrienne. And so within the committee, I just want to highlight 2 things. I want to thank you for your leadership because I really don't believe folks in community really understand the hierarchy of the local behavioral health authorities. I think that the work that we've done, you and I have together had those private conversations, and also some of the work that we've been doing at the state level. I truly believe this is an opportunity that we can expand the local behavioral health authorities and make it more finite and enforceable so that we can begin to see that change that community wants to see. I want to also underscore that as we are looking at healthcare quality from a committee perspective and a vision, we are not denying care. We are not denying care at all. We are making sure that individuals and communities receive the quality care needed in order to sustain and be better. And so I definitely applaud all of you all's effort. I did have a few questions. I know that it is only Councilman Dorsey and I. Okay, so I'll just go and I just have a bunch of questions. So one of the presentation details that Comar's 1063 revisions are intended to strengthen provider accountability and service quality to create new tools for system accountability. Can you talk more about those accountability tools and specifically one of the main drivers for the city, some of those accountability drivers for the city? Can you go into that real quick?
Sure. So what I see the department doing with the current COMAR revisions is throwing in a lot more detail, in particular, just throwing in a lot more detail. And so the way this will help us, right, is we use COMAR as the way to ensure provider accountability. So for example, when we get complaints or when we do inspections of providers, we will be looking towards COMAR to make sure that providers are, again, at a minimum, meeting what is the letter of the law, right? That's what COMAR is. So having more detail and things spelled out, like expectations around staffing and responsibility, expectations around how and when telehealth can be used, gives us more things to look at and more teeth when we are going in and doing these types of things with providers. So it raises the expectation.
Yeah, and that precisely answers my question. And I'm more specifically looking for a timeline, any timeline for execution, any ways that we as the committee can help. I know for me, just having an opportunity to convene providers. I know I spoke at the December provider meeting, and that was really informative because I got to providers in the industry got to connect with city government, and I got to connect with the providers as well. And there is a large group of providers that you all work with. How are you all integrating them into this process? Like, if you can just go through that process.
Oh, yeah.
I understand there'll be additional details, but do you have a scaffolding of what those additional details are, some of the areas that you're looking for evaluation that'll help?
Yeah. So we convene providers in Baltimore City on a regular basis, quarterly, and provide them with updates. COMAR has been a regular point of update for our providers. We've also worked with the department to convene stakeholder meetings, not recently, but I believe it was last summer, to convene stakeholder meetings with providers to get their input onto COMAR as the department was working through their revisions. But I do anticipate once the COMAR regulations are final that we will be doing something locally to not only alert providers to these changes, but walking them through in more detail. I don't yet know what that plan is. Part of it is because I'm not sure when these will officially be final, and we're hesitant to say, hey, come together, let's look at these different changes until we know what is what, basically. But in our role as the local behavioral health authority, once they are final, our plan is to convene the providers, probably as a group, but then also as different provider types to go through the changes. They need to be aware of them. I'm also not sure what the department's plan is in terms of how long they're going to give providers to get into compliance. I imagine some are not quite there yet. So we need to know those details. We need to know those details in order to be able to plan. But that would be our general plan, is we will work with providers to make sure they're aware. We will also work with them to help get them into compliance too, right? That's part of our role.
I love that, and that's a great transition into my next question relates to technical assistance. So we know that there's going to be a gamut of providers, that some that are in compliance, some that are near compliance, and some that are fully compliant. And I would encourage you to use this committee with regard to kind of getting information out there, but also leveraging different providers that are not connected to BHSB. So maybe like a social media toolkit. So I know Kristen Kuzer is on the line as well for provider relations, really beefing up those provider relations and using the council as a conduit to that. One of my big concerns, and I know I shared this with you, there are some providers that are connected to BHSB, and there are some that are not connected to BHSB. And so those ones that are not connected to BHSB, those, I don't want to speculate, but I have no bearings on how they are performing. And so that needs to be those 2 points need to be connected. And so using this council as a conduit to that, I know we've done some things with the opioid restitution office to that same effect as well. So using the council as a leverage to get that out into community, that would be very helpful.
We will. Thank you for that. Thank you for that support. You've highlighted in your comments one of the ongoing challenges that we've had, which is providers are not connected to their LBHA, and they should be. We think that's an expectation that needs to be more spelled out in COMAR. So, yeah.
Wonderful. The next one is telehealth restrictions. So Maryland is an enabling provider state, and I have had, while I understand it in theory, I want you to kind of talk through the telehealth restrictions or the new telehealth restrictions from this COMAR 1063. And if I'm misspeaking, because I am still trying to really understand the telehealth restrictions, can you go over them real quick for us?
So I only looked at them for the PRPs for this program, but one of the reported challenges with PRPs has been that all services are providing, is that providers, some programs, not all, but some programs have been probably overutilizing telehealth. So the language that has been proposed in COMAR is to put some restrictions around when telehealth can be used. So it is not permitting, as drafted now, it is saying that PRPs may not use telehealth to provide group services. Those have to be in person.
Okay.
The other limitation is that PRPs may only provide, for individual care, 50% of those appointments or sessions need to be in person versus
And
telehealth.
how is that being monitored? You know, one of the big challenges that I know you and I have talked about is the monitoring of these services. And even, you know, before the moratorium, it was an issue with monitoring of those services. So how is that being monitored?
So that would be looked at through claims data through the
Okay.
public behavioral health system.
And
Yeah.
so would they be reported back to you all as like, how does that reporting structure work?
That piece would be reported to the state, but it would be, if we got a complaint about something like that, that would be something we would look to the state to get data on. It'll also be something that the state, and again, when these go into effect, it would be something that the state and BHSB would look at when we're monitoring providers.
Are you all interested in having a specific kind of monthly data dump into BHSB so that you are, you know, iteratively, checking on those criteria?
We are very interested in getting more claims data from the public behavioral health system. It is something that we're working on with the state. It's not something we currently have. Part of that is because the state changed ASOs. We are about a year into having a new administrative services organization that is the payer for services of services within the public behavioral health system. It is now Carillon.
Yep.
They are still working through. It's a long transition, right? Transitions through ASOs are 18 months or more until things are working smoothly, and sometimes things still have hiccups, right? So the data dump and getting LBHA's claims data is a piece that they are aware of. I don't know the timeline for when that'll be addressed, but it is important data for us to get. We can get it when we make requests around, you know, when we're doing investigations or looking into certain provider types, but having that regular systematic thing that you're talking about is still something that we do not have. The state is aware, though, that it is something that all LBHAs want and need to focus on accountability and quality.
Great. I would love to explore that. And the reason why I bring that up is because, you know, as a kind of clearinghouse for some of our problematic operators, we have them. You know, we have that list. I'm pretty sure you're very detailed, so I'm pretty sure you have that list of those operators that we are that have significant challenges. I wonder if there's an opportunity each month to just get a claims data on those providers, you know, and so it really provides an opportunity for us to not just totally get all of the data coming into Baltimore City, but really looking at a targeted approach to those problem operators that we know have complaint after complaint after complaint month over month.
Yeah, and what you're pointing to is something that can happen, right? If there are programs that have a pattern of not being in compliance or a pattern of complaints, that does sometimes lead to the state and BHSB putting a provider on a performance improvement plan. And when they are on performance improvement plans, regular look at data, regular look at how they are moving forward to address the findings or the recommendations in a performance improvement plan is something that we do in partnership with the state. So again, if there are providers that kind of fall into that category, we do have some tools that we can use and data to help kind of move that forward. But again, I'll just emphasize, because for their community members who are listening, please do send us complaints. Those are a way for us to go in and look at providers and work with them on a regular basis to improve their quality. So we do encourage people to give us complaints. We don't necessarily look at those as a bad thing because, again, it gives us an opportunity to go in and document and work with providers.
And I think that, you know, with regard to the committee, that's an opportunity for us, you know, to push that information out on our social media platforms, our newsletters, but more importantly, to actually work on an accountability toolbox for you. Kind of making sure that we are staying in connection, whether any clinic in our said districts is on a performance improvement plan, we should know that. And so I would definitely love to, over the next quarter, working with you on how we can develop that strategy for tracking and documenting, but also making sure that council members have an acute awareness of where those hotspots are within their community. And then also having those communication tools to share out through their platforms as well.
Yeah.
Wonderful. Ryan, any questions? Well, okay, I'll keep going. You're doing great. You're doing great. Last two questions. One of the ways that I was a little bit disappointed with regard to Comar 1063 was not having more enforceable language to the agreement to cooperate.
Yeah.
And I know that is a major, major lever of BHSB. How are we moving forward, or how are we pivoting from that language not being represented in 1063?
Yeah, we share that. So again, I'll highlight the Comar regulations, the draft that we have now does add language that allows the LBHA to do pre-inspections or pre-site visits before issuing an agreement to cooperate. So we do see that as progress. Having that in language or in Comar sets an expectation for providers, one, that they should expect to hear from us and not just automatically get this document. So we do see that as progress. In terms of next steps, one of the things that we've also highlighted for the department is that we think the language in the actual agreement to cooperate needs to be strengthened as well. The language now is, in our opinion, pretty broad and just emphasizes that providers are expected to coordinate with us when they get complaints. It uses language like coordinate, so we think there could be stronger language added in there. And also it adds some language that, again, outlines the expectation that providers are expected to engage with their LBHA. So kind of to get to that challenge you were talking about in one of your earlier questions around providers not knowing that they need, and us not knowing about them. So that is a conversation we are continuing to have with the department. I do think there's an interest there in terms of a timeline and when they're going to get to it. I don't know, but it's not something we're going to give up on, because we think it's a huge opportunity and just another way, again, that we can strengthen expectations for providers on how they need to work at the local level.
Yeah. And quite frankly, I think we have to still keep trying, because the amount of emails that each of us are getting, the phone calls related to problematic providers, or really folks not understanding what true harm reduction is, but also healthcare delivery is a major, major issue in communities. And so that's really why we're having these conversations, like how can we share proper, accurate, quality information with community so that they experience addiction and recovery in a positive format instead of always thinking about it in a negative format. So I love that. My last question has to do with state requirements. And if this is something that we need to follow up with BHA on, that's totally fine. When we're talking about state requirements for follow-up with wraparound services for post-patient treatment, are there specific requirements for PRPs are there specific requirements for PRPs related to follow-up with wraparound services and or post-patient treatment?
So I don't recall seeing anything specific to that in Comar in the current draft. So but I would like to check and follow up with you on that.
Yeah, and that can be an official committee request, because the reason why I bring that up is, a lot of the issues that people bring to us are post-patient treatment. And so
when you say post-patient treatment, do you mean post-hospitalization or?
No. So post-patient treatment, I'm talking about, and this is something that I recently got from the literature, it's what happens with job placement, vocational training, childcare, housing. What are the specific requirements that PRP actually has to do that? And how they are documenting those outcomes within their operation.
So then thank you for clarifying for me. That helps. I can answer partially, but I still want to follow up to get more detail, because I just don't remember everything that I read. So there are some service delivery requirements in the current draft of Comar. I do recall that there were some around supportive employment and outcomes there, but I want to check on what else is in there and just get back to you. Again, it would be what's in the current draft. Doesn't mean it would be final, but there are a few things in there.
Yeah, and specifically, I'm looking at measures of success. And so another major issue when folks contact us, they're like, Felicia, it's just like a churn. Persons are going to clinic to clinic to clinic. What is the measure of success that the department is looking for, and then what we can look for at the local level, integrated within our inspections? How can we, how can we measure success based on that, so that we are truly getting the full scope of recovery?
Yeah.
Okay.
Yeah. I mean, I can say there are not system level outcomes for the public behavioral health system. The state doesn't have anything like that they look at to point to for success. The state does have for BHA, through the state's outcomes-based budgeting process, they do have outcomes that BHA is supposed to work towards, and those are things like increasing utilization of the public behavioral health system. There is a measure around looking at our people continuing to stay connected to care like 45 days after engagement in program. I'd be happy to send that as follow-up also to the committee so you can see what those are. Those are specific to the department. So in my mind, I look at them as a little bit different than system level measures.
thinking, yeah.
But when you do look at them, there are some things I think you could pull out to get a sense on how we're doing at a system level.
And I'm also, I know we have some of our hospital partners on the call as well. I'm also really looking at how we kind of integrate our hospital institutions within the system of, within the systems thinking approach to recovery. And so I would love to make sure that we are connecting those dots to make sure our hospital institutions are acutely aware of those measures of success and are working with our health clinics in community so that we have a full connection of care from institution to community and vice versa. All right.
Yeah.
All right. Any other questions, Ryan? All right, cool. The last thing I wanted to say is I just want to highlight a success of the committee. So probably like 2 months ago, I requested a list of city-owned buildings related to naloxone, and I just want to shout out the health department and all the people that worked with developing those lists of city-owned buildings that will house naloxone. It is a priority of this committee to make sure that access is not a barrier. And so that will be a great opportunity for us to have the blueprint for other opportunities for city-owned buildings and or community buildings to have this level of access for naloxone. So I don't believe we have any public testimony. All right. Thank you so much, everyone, and I look forward to the next hearing. Bye-bye.